Welcome to this episode of the Fertility Podcast, which is coming to you on the 30th of March 2020, where we're in such an unusual situation. We're all on lockdown, and I just hope you're all right, because it's a bit of a head fuck, isn't it? This is where I have to put this episode as illicit in my iTunes. So I just wanted to explain what's going on with the Fertility Podcast, because the episode you're going to hear is a previously recorded episode. We've got quite a lot of archive to share with you that we haven't yet published. But what Kate and I are also wanting to do is share your stories, especially in light of a lot of people having their treatment cancelled. And this week just gone, both Kate and I weren't actually very well. Both of us think we've had mild coronavirus. Very mild compared to what we know people are struggling with. But it means that we had to cancel some of our recordings. But we are still checking in with those of you that are wanting to share some of your stories. So do expect some extra episodes. Be sure to subscribe to the feed over the coming weeks, because we're putting all sorts of different bits and bobs out, along with what we had planned. That makes sense. I've been umming and ahhing about the intro to share with you, because I don't know about you, but I keep waking up thinking, oh yes, no, it is actually still happening. And it's just something that we couldn't have predicted how it would make us feel. And it's taking such a lot of getting used to for so many of us. If there can be some constants with things like this podcast, then I really hope that it continues to help and support you. And I'm just working out what else I can do in the work that I do to support you. This episode that you're going to hear, however, is a really fascinating chat that Kate and I had with a lady called Dr. Christine Ekechi. Now, Christine is a gynaecologist and obstetrician, and she works with Black and Asian women. And what we were talking about were the issues that affect Black and Asian women in communities, talking about infertility, myths around fertility for men and women, and also the assumption of certain issues like fibroids and polyps and endometriosis. Christine was so interesting. Kate and I met her in the British Library in February in half term, and stupidly, I thought we'd be able to find a space where it would be quiet, but we couldn't. So there's quite a lot of background noise, and we have worked on the audio, but just bear with us, because it's not the usual kind of recording quality, despite the three of us being huddled in a space. I'll share some pictures of where we were stood. Please do let us know what you think of this episode. Be sure to rate and review this episode if you haven't yet, because with so many more people listening to podcasts, the more kind of engagement we get from you supporting what we're putting out just means that hopefully more people will find us. And I am seeing on Instagram people sharing the podcast that they're listening to. And if you have been listening to this podcast and you haven't yet kind of talked about the fact that you've been listening to it, please do. It really does help. And I don't ask often enough for your support in terms of helping other people find what we do. So now more than ever, we'd really appreciate it. You can tag both of us. I'm at Fertility Poddy. Kate is at your_fertility_journey. You can use the hashtag Fertility Podcast. And for now, enjoy this episode. Stay safe, check in with your loved ones, stay at home, and we will get through this.
My name is Dr. Christine Ekechi. I'm a consultant obstetrician and gynaecologist based at Queen Charlotte's Hospital, which is part of Imperial Private Healthcare. I work as an early pregnancy specialist, but I'm also an advocate for women's health, and specifically focusing on the ethnic disparity in health outcomes for women, particularly for Black and Asian women in the UK.
And that's something that I've talked about a bit on the podcast. When I was hosting the Stage of the Fertility show, it was a conversation that we had. And there was such stigma about infertility anyway, but we know it's really prominent when you are in a community where fertility is kind of an assumed pathway. Talk to me a bit about the issues that we need to overcome and how we need to, in essence, change the narrative and help people access the information more.
Well, in a way, I find myself being in such a unique position because not only am I an obstetrician and gynaecologist, but I'm also a black woman. And so, in a way, I identify with a lot of the issues that black women present when they present to myself or my colleagues with these particular concerns around their health generally as a woman, and particularly with regards to their fertility. Now, when I was growing up, you have both obvious signs and conversations and also the sort of messages that you take on subconsciously about how virile and fertile I, as a black woman, am supposed to be. So, if we think back to cartoons and films we watch, there's always sort of black women with 5 or 6 children, and then invariably my mother would talk about some mythical great-grandmother who had 20 children. And so you sort of take on these messages, right? And I think it's then extremely hard when you then get to your reproductive years and you find that there may be challenges in that area. And the difficulty is that if you grow up with these narratives and frameworks about how fertile you're supposed to be, you have a bit of an argument within yourself as to whether it's true, whether it's valid, if you're having these difficulties. And then you may find that you have very few people to talk to and reflect upon some of these issues. The other problem is that because there is the stigma that abounds, most people don't talk about it. Now, I have to say that in a way there is very much a conflict between infertility and talking about it very much in the Western world and how it's approached in certain other cultures. So my family are Nigerian, and inherently the whole idea about who is a mother and what is a mother is much more broader than it is in Western society. So, in Western society, a mother is somebody who has a child that shares their DNA and they deliver that child via their body cavity. Whereas in many other cultures, actually a mother is anybody who takes on the role of looking after children, whether or not that child shares their DNA. And so there are many, many stories I grew up with of women in my family who sort of unofficially adopted children, and that was seen as a very normal thing. But as sort of, cultures from Black and Asian communities take on a lot of the Western narratives, we find that there is this greater stigma and sort of push to have to be a mother for a child that shares their DNA. And we're seeing that real sort of conflict, I think, between these two ideas about what motherhood even means in the first place.
I love that idea of just lots of aunts. I mean, it is something that's prominent, in my upbringing, but I know it's something that's really prominent in different ethnic communities. And I wonder whether they were women who did suffer from fertility issues and it just was never spoken about because it was even less spoken about then.
Yeah, so I know of sort of women in my family who were unable to conceive their own children and took other routes that was very much accepted in our culture, but it's never spoken about, it's never actively spoken about. And if it is, it's very much with hushed voices, but also an acceptance, really, that this is what was done. And there was no sort of difference made between who had their own genetic children and who unofficially adopted other children. And I think that's great. It was great in this whole extension of what family meant. But also, in a way, it doesn't really address maybe some of the pain that those individual women felt at the time, and they felt that they could never talk about and never address because it was never discussed. So I don't want to completely sort of romanticize the idea. In a way, one of the great things is that we can talk more openly about it, and I think this is something that the Black and Asian community is sort of moving towards. But, I think when we're trying to push against the narratives, it's always very hard at the beginning.
So, obviously there's barriers to talking amongst family members and themselves about these issues, but we also know that there's barriers to women seeking treatments. So as an example, the HFEA treatment cycle figures that we have, we know that in 2018, for example, white British women, there were just over 43,000 cycles of IVF. But in comparison with Black African, it was 1,386. Why do you think that's so low?
So it's a number of factors. Number one, you have to have the awareness of infertility as an issue in the first place. So if we go back to the beginning, if you are not aware or have the basic education as to how your body works, it's going to be very difficult to then identify when there is a problem. So that's the first thing. The second thing is we've talked about the stigma when it comes to difficulty with conceiving. And so that presents a very huge barrier to asking for help and presenting for care. The third is that we have the religious component. So I was made aware of a friend who had declined any sort of assisted reproductive technology to help her and her couple to conceive, or her and her partner to conceive, because she said it was against her religion, which was sort of news to me because I knew this girl to be Catholic. And so when I asked what she meant, she mentioned their sort of concern about what happened to unused embryos.
I've had that with patients as well.
Yes. And so that opens my mind to this idea of how this presents a conflict for many people when it comes to trying to seek help for infertility. And then we have to talk about the financial barriers, which is a huge one. So when you look at the majority of women or couples who are able to access fertility treatment in the first place, they are normally in a sort of middle to higher income bracket anyway. These are people who have to access fertility care outside of the NHS. And so that is a huge barrier for so many women and couples seeking help. When it comes to the NHS and seeking help via the NHS, well, you have to be aware of the postcode lottery, and you have to be aware of the barriers in the first place, for example, in terms of age and whether you have children already. And what I found is that so many women are just unaware of the sort of barriers in the first place, so that by the time they do present, it's almost too late. And then finally, we need to talk about the impact of other medical conditions that can stop women from conceiving in the first place, and most notably fibroids, which has a greater prominence in the Black and Asian community.
That's so interesting about that first point that you said there about raising awareness and lack of awareness among the Black and Asian community about their bodies. How do you think we can improve awareness about fertility?
Well,
good question.
It's an excellent question. I mean, I always say that the only reason why I'm clued up with regards to my own gynecological health is because I'm a gynaecologist.
Yeah, I get that.
Right. So if I think back to when I was at school, I mean, it was the 19 bleep.
You're not that old.
You're younger than us.
But I vaguely remember not much, to be honest. And
Because it was all about how not to get pregnant.
Absolutely. Do you know what? Absolutely. All I remember was coming away with this feeling that I could not get pregnant because my mother would literally kill me. And then I remember walking away with a lily white sanitary pad. I am that old. So that's all I vaguely remember from my sexual health education. My mother gave me a book at the age of 9 and sort of said, which was quite radical actually for sort of Nigerian mothers at that time. She gave me a book and said, I think you should read this. And I remember sort of learning about periods and so on. But to be honest, my greatest education with regards to my own health as a woman came via medical school training. And clearly not everybody goes to medical school. So, one of the things that I'm really focused on and passionate about, passionate being an overused word, but I think is really relevant in the setting, is really starting from the basics. So educating women, arming them with the words that they need to be able to advocate for themselves when they then sit in front of myself or colleagues to describe when problems are occurring.
Because there's definitely more of a movement in the awareness sense. We were just talking about an event that you're putting on, which we'll talk about in a second. I was telling you about some of the people that I know from the TTC community, predominantly on Instagram, who I've been talking to. One is Vanessa Hay, who is Black, and one is Jazra Badia, who is an Asian woman, and both have spoken with me at length about how they didn't see themselves represented online. And so when we're talking about, again, that awareness, it's that, I suppose, encouragement to give women the courage and the strength to be more open, because both of the women I've just mentioned talked about how now they are putting themselves out as the voices. They're being inundated with women saying, thank you, I thought I was alone, because there is this wall of silence, isn't there?
Well, there's the saying that you can't be what you can't see. And I think you can very much extend that to say that you can't attribute relevance to particular issues if the imagery around that doesn't reflect you. So if we look, historically around the imagery with regards to infertility and fertility treatment, it was very much, a white heterosexual couple, middle-income couples. And so if you're walking past adverts, sort of talking about infertility, you invariably subconsciously are taking on the message that it doesn't affect you, or doesn't apply to you, or the treatments are not for you. And I think we're starting to understand this. So a great example is with regards to cervical cancer screening. And historically, again, imagery was very much homogenous, sort of like women. What we know is that Black and Asian women have the least uptake for cervical screening. So Public Health England have taken this on board, and the latest sort of adverts advocating for screening use a lot of imagery using Black and Asian women, and it's very, very important, so that when people see that and they see people that look like them, then they are more likely to take on the messaging. And this very much is important when it comes to fertility treatment also.
Do you want to talk a bit more about the fibroid issue and how much awareness there is about that?
Well, now there is increasing awareness. So I normally say that if I were to take my ultrasound probe out to Westfield, I'll find that 13% and upwards of women will have fibroids. And then I go on to describe minimally base, which I don't, I'm terrible. But if you're sort of got the rolling pin and you're rolling out the dough, you have some knobbly bits within it, and that's essentially what the uterus is like. And some of those knobbly bits are a bit smaller, some of them are a bit bigger. So they're benign growths of the muscle of the womb.
I was always described that the fibroid looks like a peeled onion, you can peel the layers off. That was
Yes.
The gynaecologist told me that once when I was working in Oxford.
So that's probably a gynaecologist that enjoys doing one of the operations called a myomectomy. Yes. And for the most part, they can be very much, benign. They are benign. But when they cause problems, very much depends on their size and their location. For most women who don't realise they have fibroids, if the fibroids grow to a particular size where they impact on the integrity of the tubes, so the tubes that are required to be opened to allow successful pregnancy, then of course this poses a problem. Now, I think for most women, or at least the women that I have met, they tend not to realise that they have huge fibroids, so they attribute their increasing size of their stomach to eating habits and not exercising, and they try everything they can. Then, of course, there is the fear of approaching medical professionals, and I think as medical professionals we have to acknowledge that for some women, particularly Black and Asian women, there is this fear of not being heard or not being given the best care. And sometimes that fear can be valid. And so that tends to mean that Black and Asian women present very, very late and later in their reproductive years. And then we have to decide whether we're going to try non-intervention or later intervention, which requires surgery. And of course, many women are fearful of surgery. So normally what I say is that it's very important to try and determine whether you have fibroids in the first place. Now, if you have fibroids, it doesn't mean that they have to be removed. And, I, as an obstetrician, have managed many women who are pregnant and have huge fibroids. So it's really important to stress that fibroids does not automatically mean infertility or automatically mean that they need to be removed. But we have to assess that in the context of a woman who's trying to get pregnant, and early intervention is always better.
Are they genetic?
So again, good question, and I think there is an increasing movement to try and actually improve our education around fibroids. The truth of the matter is there hasn't been the dedicated level of research to really understanding about fibroids and why some women get them and why some women suffer more severely than others. To be honest, I guess it just wasn't a research priority. And yes, we could argue that that very much was dependent on the women who were affected by it. This is where I think grassroots advocacy really helps. I think as a community we need to advocate more for ourselves and to really try and push the research agenda. But of course, invariably, research requires money. And I think every time there is constraints on money when it comes to research, it's going to be diverted to the areas that shout the loudest.
I read a really interesting article actually, which is called for an overdue clinical study on vitamin D and fibroids, and how they now feel that vitamin D potentially could reduce the size of the fibroid and alleviate the symptoms. Obviously, it needs to be researched, but I thought that's really interesting because vitamin D is so easy for everyone to take or to get out in the sunshine and get your dose of vitamin D. And if that might help, then that's a fantastic step in potential research, isn't it?
Yes. I mean, there are lots of theories now around fibroids and what may affect their growth and their symptoms. Sort of going way back to when I was at medical school looking at estrogen levels. I remember some story about it was related to the amount of yams that somebody ate because of estrogen and so on. And I think it's important to be careful because in a way we can maybe show correlation that isn't causation, i.e. there may be an association, but it doesn't necessarily mean that if you were to reduce your yam intake, your fibroids will get smaller and vice versa. But what it does show is that we need more research in that area. I mean, something like vitamin D is inexpensive and is not harmful. And we are showing that vitamin D does have some correlation in many other areas, not least the association with miscarriage. And so we are advocating women to make sure that when they take pre-pregnancy vitamins, that it contains vitamin D. And bearing in mind that all of us in the UK, irrespective of the degree of melanin we have in our skin, are probably going to be vitamin D deficient. So that's one easy thing that we can do. But I think for now, what we need to say is, what do we have within our arsenal now, our tools, to really make sure that we can present ourselves in the best possible health? And this is being aware in the first place, speaking with a doctor, asking for a scan, asking to see a gynaecologist if you're having symptoms and not waiting until it's too late. We did ask about sort of genetics, and we do know that if your mother or sister has fibroids, you are more likely to get fibroids, but of course we haven't been able to determine sort of clear genetic.
Let's talk a bit about the work you're doing with the RCOG.
So, amongst the many things that I do, I'm working with the RCOG. I'm one of the champions for the Women's Network at the Royal College of Obstetricians and Gynaecologists, which is an excellent group that really focuses on putting women's voices at the centre of everything that the Royal College does, which is so important. And our focus, not only for this year, but going forward, is really looking at the ethnic disparity in health outcomes for women. So this has very much been propelled by the latest statistics that show that black women are 5 times more likely to die whilst pregnant compared to white women, and Asian women are twice as likely to die. And this is something that, of course, is unacceptable. Of course, I should point out that maternal mortality in the UK is thankfully extremely low, and I'm really proud of that. But we need to make sure that we don't have these huge disparities between ethnic groups, no matter how low overall maternal mortality is.
What would you like to see more of?
Well, I think the first thing which we are starting to do is to de-homogenize, if that's a word, the imagery that we use. That's the first thing. I think the second thing is that we need to have more people of black and Asian backgrounds in positions such as mine. The statistics show that there are fewer of us around. In fact, the British Medical Journal has launched a really just brilliant edition, which is titled Racism in Medicine, and one of the articles looks at differential attainment, which is the term that shows the difference in outcomes for doctors of ethnic minorities. And whilst there are a huge amount of ethnic minority medical students who qualify, there are very few that then progress to become consultants and consultants with teaching hospitals and then flourish. And the problem with that is what we're seeing in terms of reflecting the population and the populations that we serve. Of course, there will be a concentration of black and Asian doctors, in the big cities and in London. But then you're right. What about black and Asian patients who would like to have somebody who looks like them and maybe reflect some of the issues that they think they may understand? Though the caveat is, I don't necessarily think that if somebody is a black patient, that having a black doctor is necessarily the best for them. It's who you connect with, but it's about having a choice. We are there. I think really what's important is to have somebody who listens and have somebody, a medical professional, that puts you at the centre and individualises your care, irrespective of their sort of ethnic background or even indeed their gender. But I think we also really need to make sure that we create the opportunities so that we have the black and Asian doctors that reflect in different communities. I mean, of course, there are certain things that I wouldn't understand from sort of the Asian perspective, or maybe the Hindu religion or the Muslim religion. I may have maybe a slightly better understanding, but there are many sort of subtle things I wouldn't understand. And I think it's very important in trying to entice women and men from those communities to come forward, because they may feel more comfortable being able to speak to somebody that reflects their background. However, I think the great thing about sort of the internet and social media means that sometimes you're not limited totally by your geographical location. Information out there. You know, organisations such as the RCG are really sort of working hard to make sure that the information and guidance that they put out there is reflective for all populations, and I'm working with them towards that, and for me that's an exciting sort of position to be in. There are also great charities such as the Edith Hill, which really focuses on women's health and the 5 gynecological cancers, and they do great work reaching out to different communities, but also the LGBTQ community, but also Instagram. I think Instagram is a great resource. I mean, there are lots of sort of facts out there, but there are also lots of brilliant people, such as, for example, Gynaecologist, Anita Mishra, who is a junior registrar, who's brilliant. And her book, Gynae Geek, I think is just a fantastic book of just educating people with the basics. I bought the book and gave it to my cousins, and hopefully they will give it to their friends. So I would say, you know, if you find that you're struggling where you live, just sort of look outside that, reach out, you know, online, and find patient groups as well. I think that's also very important and very useful resource.
We'll make sure we put all the links to those resources that you've said, because we're all about sharing the knowledge. Thank you so much for your time. It's been really, really interesting.
So interesting. I could talk to you forever. Listen to you talking forever. That's great.
Thank you very much.
Please do rate, review, subscribe and share this podcast. We love hearing from you and knowing what you think. Thank you as always for your support, and until the next time.